Topic of the lecture today is Aspergillosis. Aspergillosis is a group of diseases which occur because of a fungi called Aspergillus. Now, this is what it looks like. It's found ubiquitously throughout the soil. It means ubiquitously, the word meaning ubiquitous is found everywhere. So it's found everywhere throughout your soil, and it's found in decomposing matters. It can be plants, it can be animals, and a very major thing about Aspergillus is that it's very adapting in nature. It's very adaptive throughout its life forms, throughout its life. It has adapted through physical stresses, biological stresses, through all of that. It has adapted. And what's the newest niche for Aspergillus? The immunocompromised patients. These drugs, like chemotherapy drugs and radiotherapy drugs, and in radiotherapy, even the patient goes immunocompromised. When the patient goes immunocompromised, the ideal host for Aspergillus it becomes. So many asthma patients are also sensitive towards Aspergillus species because whenever they are somehow in contact with them, they develop hypersensitivity reactions. And other group of patients which get affected by Aspergillus are those patients who have any leukemias for a very longer time. And other patients who get affected are just immunosuppressive patients or patients who are already suffering from immunocompromised disease. Now, this is a group of patients which are constantly at risk of getting aspergillosis. So, aspergillosis is not one disease, it's a group of diseases. And it is caused by what? It's caused by Aspergillus, which is actually a fungi. And what happens is that these are present everywhere. So it does not matter where you are, you cannot avoid them. Only avoidance that you can have is that your immunity is up to the mark, that you won't get infected by this kind of pathogen. So let's talk about it. What are the risk factors? We were just talking about some major risk factors. Now let's talk about all the risk factors which are responsible for causing this disease, because it can happen to anyone. What are the risk factors which make sure that this disease is going to happen to this patient, or this disease is not going to happen to this patient or person? So first of all, what is that? Neutropenia. We just talked about it. Leukopenia, neutropenia. Now these are very basic risk factor. What happens is that they're responsible for your immunity, and if they're down somehow, and if their quantity is down somehow, what happens? These opportunistic infections come in and cause the pathology, because there's no advanced system present which can defend your body from these kind of infections or pathogens. Next on, we have neutrophil or phagocyte dysfunction. Why neutrophils and phagocyte dysfunction? Because neutrophils and phagocytes are the first defense your body has to offer. In this kind of pathology, in this kind of circumstance, what happens is that neutrophils come in, they try to kill that organism, they try to kill that pathological surfaces, or they will try to compensate, they will try to kill them. But at the same time, phagocytes activated, they will try to engulf these pathogens. But if both of them are going through some kind of dysfunction, it means that there's no backup whatsoever inside your body. So these opportunistic infections are going to take advantage of the situation and going to lead to aspergillosis. Next, we have glucocorticoid use. We just talked about these immunosuppressive drugs. What glucocorticoid does is that it suppresses your immune system. When your immune system is suppressed, what happens? Any opportunistic infection can come inside of your body and cause infection, cause the pathology it has intended. So immunity levels are supposed to be up to the mark to avoid this infection. Maybe all of us, maybe all the healthy individuals are exposed to this kind of antigen, this kind of pathological consequences on daily basis. But what happens is that we have major amount of neutrophils, major amount of phagocytes. When both of these are already present, they'll provide our first defense. They won't let the pathology go on. They won't let the pathology happen. They won't let these fungi cause aspergillosis inside our body. And next, when our immunity is up to the mark, it will produce antibodies. It will just kill these organisms. But if glucocorticoids are being used and your immunity is down, but if neutrophil or phagocytes are down due to any kind of dysfunction, or if there's any kind of neutropenia, now that neutropenia can be because of anything. It's not like it has to be because of this one reason. This neutropenia can be because of multiple reasons. It can be because of a chronic illness. It can be because of some acute illness. Whatever the reason might be, if neutrophils are down, if phagocytes are down, and if you're using glucocorticoids, and your immunity is down, what happens? These opportunistic infections, these opportunistic organisms are going to cause infection. Next, now we have pulmonary disease. What's that to do with aspergillosis? Because how do we get these fungi? We get them through inhalation. So, what's the first system they're going to get through? That's our respiratory system. That's our lungs. And if it has any kind of pathology, it's going to actually aid them in causing this disease, in causing these diseases of aspergillosis. Next on, we have immune suppressors. We talked about them. The glucocorticoids are one of them. And then immunosuppressors can be many, like chemotherapy is one of those. Chemotherapeutic drugs are one of those drugs which cause immunosuppression. So, any of these factors are responsible for causing this pathology. It cannot happen on its own. It cannot happen in a healthy individual because its immunity is up to the mark. It has enough amount of neutrophils and phagocytes to provide the first defense, and you're not taking any immunomodulators or any drugs which are suppressing your immune system. So your immune system is up to the mark, your lungs are up to the mark, they are providing that barrier which is required, and they're killing pathogen in itself. Number three, we have no use of glucocorticoids whatsoever, and neutrophils and phagocytes are there, and there's no neutropenia whatsoever. Now, these are the risk factors which can be a major criteria for causing the disease. If all of these are present, if there's any pathology going on, like if there's any neutropenia, what happens? The opportunistic infections of fungi are going to cause this disease, are going to cause these diseases of aspergillosis. But if all of it is up to the mark, nothing will happen and it will just go away. Next on, we have pathogenesis. What happens when it gets inside your body? What's the pathogenesis of it? First of all, what happens? We just talked about it. Their way of getting inside our body is through inhalation. They're airborne, they're present in the air. So, what happens? We inhale them. When we inhale them, it goes to the alveolar level. At the alveolar level, what happens? As you can see, this is that particle which is coming in, it gets to your alveoli. And what happens? It's going to stick to one of your alveoli. It's going to get inside of it, and it's going to cause infection in your alveoli. In that one alveoli, it's going to cause infection. When the infection is being caused, it goes through. But before going through, what's being produced? You can see E. What do you mean by E? E meaning those patients who we just talked about, that some asthmatic patients are sensitive towards these species. So they're going to develop allergic reactions, allergic symptoms. So allergic symptoms will be produced right here when it's infecting your alveolar level. So what happens is that after invading through this, it's going to invade what? Your blood vessels. That's what's called angioinvasion. Angio means blood vessels. Invasion means it's going to invade your blood. It's going to invade your blood supply. Once it invades your blood supply, there's no stopping that, because now the spread is hematogenous and it can go anywhere. So what happens afterwards? It's going to disseminate. It's going to disseminate inside your blood supply. It's going to get to your vessels. It's going to get to your epitheliums. It's going to get to all the region it wants to, because now it has spread in the blood and the blood goes everywhere. It's going to get attached to epitheliums. It's going to cause damage inside of them, and it's going to get to all of those organs which are specifically at its target. So what happens is that, as you can see, this is a fungi which is which is producing these airborne pathogens, what happens? At the time of sporulation, when all of these spores are airborne, when all of these spores are just let go of, what happens? It goes inside your nasal cavity, it goes inside your nose or your mouth and makes their way into the lungs. That's what's called inhalation of airborne conidia. Next on, what happens? It gets to your alveolar levels. And conidia germination in absence of sufficient pulmonary defenses. We talked about it. If there's any pulmonary pathology present, it's going to aid this pathogen to get to our systems, to get to the pathology it has intended. So what happens if there's no pulmonary defense present? It's going to go through. But if the pulmonary defenses are present, they might even deal with it right here, and this infection won't go through. This infection won't go through your blood supply, won't infect all of your other systems, and even in the blood. So what happens is that if there's no sufficient pulmonary defense, what happens then? These ciliated cells get affected. This basal membrane is going to get affected and lumen, as you can see. What happens afterwards? There are two options we have. Either we have corticosteroid induced immunosuppressions, which is called by immune recruitment and tissue damage. Now what happens is that when these spores are there and there's immunosuppression present, first there was no pulmonary defenses present because of any kind of pulmonary pathology. It can be asthma, it can be any chronic pathology like COPD. Due to any of that, now these spores are present inside your lungs and they can cause their desired pathology. So what happens is that it has two options afterward. Either the patient is also, first, it has a pulmonary pathology, second, it has taken an immunosuppressive drugs. So what happens? Tissue damage is going to happen. Next on, if there's neutropenia, excessive hyphal growth and dissemination will happen, and this will also lead to the desired pathology. So we talked about those risk factors. Any of those risk factors is down, any of those risk factors is like positive, it's going to lead to these kind of pathologies. If it's neutropenia, it's going to cause hyphal growth, excessive hyphal growth, and then lead to dissemination we talked about in the last slide. And then on the same level, if there's some kind of immunosuppression, it's going to cause a recruitment and tissue damage. Next on, let's talk about what types of diseases aspergillosis brings with itself. Now, we talked about it contains a group of diseases. So it's not like there's going to be one disease. It's going to be a group of diseases. Let's talk about which diseases might that contain. First of all, it contains invasive pulmonary aspergillosis. We talked about pulmonary levels. We talked about it's going to infect your alveolar levels. It's going to infect your alveoli. And if you're taking immunosuppressive drugs, it's going to cause what? It's going to cause tissue damage. It's going to recruit MN. And next on, we talked about if there's neutropenia, it's going to cause increased hyphal growth. And when the hyphal growth is up to the mark and excessive hyphal growth is happening, what happens? Dissemination will happen. So when these airborne pathogens get their way into the lumen of your pulmonary system, into the alveoli of your pulmonary system, it can cause invasive pulmonary aspergillosis. Invasive meaning up to very deep. It means it's the meaning of invasive is it's going to go deep inside your lumen, inside your tissue. So it's going to cause invasive pulmonary aspergillosis. Next on, it can cause chronic aspergillosis. Next on, it can cause allergic aspergillosis. Now, in invasive pulmonary aspergillosis, it's going to be maybe acute, maybe chronic. What's the definition of acute and chronic in the terms of aspergillosis? If it's going to be between 1 to 3 months, it's acute aspergillosis. If it's going to be more than 3 months, it's chronic aspergillosis. And allergic aspergillosis happens to some patients, like asthmatic patients, who are allergic to this kind of pathogen. So they produce IgE and they respond to it, and the body responds to it with signs and symptoms of allergy. So they are just allergic to it. Maybe they get this pathology afterwards. But it's not a pet thing to happen. They get this allergic reaction because of this pathogen. So we have acute, we have chronic, we have allergic, and we have invasive pulmonary aspergillosis. Now, these are the types of diseases that we are going to get because of aspergillus. So first of all, let's talk about lungs. What will happen to the lungs? What clinical features will it manifest with? What clinical features do you expect out of the lungs if they are subjected to invasive pulmonary aspergillosis, or if there's any acute infection going on, like if those spores are infecting your alveoli? So what symptoms you will look for? First of all, we have invasive symptoms. Next, we have chronic. Next, we have saprophytic. And next, we have allergic. So we'll talk about it one by one. In invasive, what happens? Angioinvasion happens. We talked about invasive. Those spores came in. They got your alveolar levels. In your alveolar levels, it's going to infect your alveoli, at least one of them. It's going to cross that barrier. And once it's going to cross that barrier, it's going to go into your blood vessels and it's going to invade them. And that's what angioinvasion is. So these are the clinical features of invasive lung disease. Next one, it will be non-angioinvasive. It can be non-angioinvasive as well. Why? It's going to contain itself inside those alveoli. It's not going to cross and it's not going to go into your blood supply. That's called non-angioinvasive. And it can be granulomatous. What does that mean? It's going to cause a granuloma inside your lungs. And what's the example of that? We have that fungal ball we talk about. That's one example of causing granulomatous disease inside your lungs. So it can cause in invasive aspergillosis. What pathologies can we see? We can see granulomatous, we can see non-angioinvasive, and we can see angioinvasive. Meaning it can invade your blood supply, meaning it cannot invade your blood supply and stop itself right at the level of lungs and infect your alveoli and infect your alveolar levels and their basement membranes. And next on we have granulomatous disease, and with granuloma will be formed and the pathology will go on according to that. Next on we have chronic. What's the clinical features for chronic aspergillosis will be like? In chronic aspergillosis, chronic cavity will be found. Cavitations will be produced, so chronic cavity will be produced. Next on we have chronic fibrosing. So fibrosing lung disease will come in, and those areas of the lungs will go into fibrosis because of continuous and chronic presence of this fungal infection, of this fungal pathology. So this will go into fibrosing. So it can lead to this chronic disease of lungs, can lead to chronic cavity and chronic fibrosing, meaning it can lead to fibrosis and cavitations inside the chronic aspergillosis. Next on we have saprophytic, which will lead to aspergilloma. Aspergilloma is a fungal mass, a ball of fungus. We talked about it in granulomatous diseases. These diseases can lead to granulomatous diseases, not the fungal ball. But the saprophytic type, the saprophytic clinical features will induce aspergilloma, which is a fungal ball. Next, airway colonization. Colonization of these spores will be in the airways. So they will colonize there and they can spread through there. They can go into angioinvasion. They cannot go to angioinvasion. They can cause granulomatous diseases. But in saprophytic levels, and aspergilloma will be produced, which is a fungal ball, fungal mass. And what happens? Airway colonization will happen. In the allergic type of aspergillosis, what happens? Allergic bronchopulmonary aspergillosis happens. What happens? Those spores come in. Those patients are sensitized towards this kind of pathogen. What will they respond? How will they respond like? They will lead to allergic bronchopulmonary aspergilloma. They will produce all the allergic symptoms and you will have to manage them as quickly as possible. Next on, we have severe asthma with fungal sensitization. We just talked about it, that some asthmatic patients are specifically sensitized towards this kind of fungal antigen or pathogen. So when they are exposed to this kind of pathogen, what happens? The whole body responds. The severe allergic reaction comes in. So we have to manage these patients as soon as possible. Otherwise, they cannot breathe. Next, we have extrinsic allergic alveolitis. In this pathology, what happens is that the symptoms of those allergic reactions that we talked about are extrinsic in nature. will see it. Maybe they're not inhaling it, but they will get these symptoms one way or another. Next on, we have clinical features regarding the sinus. What will happen to the sinuses? So what happens in invasive, it's going to be acute invasive. In chronic, it's going to be chronic invasive and chronic granulomatous. In saprophytic, it's going to be maxillary fungal ball. We talked about that aspergilloma. And in allergic, it's going to be allergic fungal sinusitis. So what kind of sinuses it's affecting? In invasive, it's affecting acutely and acutely invasively. So acute invasive sinus will be affected, and chronically chronic granulomatous diseases will come in, and chronic invasive is the pathology lying behind it. In saprophytic, maxillary fungal ball is seen. We talked about the aspergilloma type, that it's a fungal ball, it's a fungal mass. In saprophytic, maxillary fungal ball is seen, and allergic fungal sinusitis comes in. And alongside with it, we have eosinophilic fungal rhinosinusitis, meaning eosinophils will be produced in greater amounts. Fungal rhinosinusitis will come in. Next on, we have clinical features of brain. We talked about the lungs. What clinical manifestation does that produce, or what clinical manifestations it manifests? Now let's talk about the brain. What will happen in the brain in invasive and in chronic stages? First of all, in invasive type, it's going to cause an abscess. You can see an abscess right here. Next one, it can cause hemorrhagic infarction. It can cause hemorrhagic infarction, meaning the blood will be spilled inside of your brains. Many of the area will be dead if the blood supply has been compromised with a specific area. So what happens? This hemorrhagic infarction will lead to a lot of blood spill inside of your brain, that part of your brain, and it won't be functional afterward. It's possible it's functional, but it's not functional entirely. Next one, it can cause meningitis. It can cross your blood-brain barrier. It can cause meningitis. It can infect your meningeal levels. It can infect your meninges, and it can lead to meningitis. Now, this kind of meningitis is very dangerous because there's no pet way to know that it's because of a fungal infection. First of all, you'll go for bacterial meningitis and you will treat that. That's why the approach of history, examination, diagnostic modalities, and then treatment is very necessary. Because most of all, as a practitioner, you will deal with bacterial meningitis. Lesser than that, you will deal with viral meningitis. No one will think of this fungal meningitis until they go for what? Until they go for these diagnostic modalities in which multiple factors will be checked, and then you will be sure that it's not bacterial, it's not viral, it's actually fungal meningitis. Then you will treat the patient. Up till that point, you won't even know that it's fungal. So once you know that it's fungal meningitis, you have to do it, you have to manage the patient very quickly. So in invasive type, the clinical features of brain will include what? Abscesses, hemorrhagic infarctions, and meningitis. In the chronic type, it's going to cause granulomatous diseases. And what else? It's going to cause meningitis. So meningitis can be caused invasively and chronically. On the other hand, granulomatous diseases will be caused in chronic form, and abscess and hemorrhagic infarction in invasive forms. Next on, what are the clinical features of skin that you'll look for? We talked about the lungs, we talked about the brain. Now let's talk about the clinical features of skin that it will present to you with. First of all, it's going to be acute disseminated. When you think of clinical features of skin, you have to keep it in your mind that we just talked about that some patients, or asthmatic patients, or some patients are sensitized towards these pathogens. So whenever they're in contact with those pathogens, allergic reactions will come out. Those allergic reactions will include all of the skin manifestations too. So if by any chance, if you forget what the skin manifestations were like, you can think of an allergic reaction. So clinical features of skin will include what? Acute dissemination of the skin. Next on, locally invasive. It means if it's attached here, it will be locally invasive. It's not like it's not going to cross the barrier. It's going to be locally invasive. Next one is going to cause external otitis. It can get to your ear. It can cause external otitis. And it can lead to onychomycosis, which is one of its type, which is one of its pathology. So in the skin, these four manifestations will come on. First of all, it will be acutely disseminated. You can see the redness here. It will be locally invasive. It will invade the local tissue. It's going to cause external otitis and onychomycosis. Now, these are the skin manifestations that you'll look for inside a patient which is suffering from aspergillosis. Next one, what are the clinical features of heart? We have up till now we have talked about the clinical manifestations of lungs. We have talked about clinical manifestations of skin. We've talked about clinical manifestations of brain. Now let's talk about clinical manifestation of heart. Up till this point, you must be wondering that, oh my God, it's going to affect so many vital organs. That's why it's very important to stop this pathology right at the base, to stop this pathology right in the lungs. So your pulmonary defenses must be up to the mark to stop this kind of pathology, because once it gets inside of your bloodstream, once it goes into hematogenous spread, it's going to be very difficult to eradicate this kind of pathology. So what's going to be the clinical features inside the heart? First of all, endocarditis. It can cause endocarditis. Endocarditis has multiple consequences afterwards. The valves are not going to be the same, and that patient can get multiple other diseases anytime afterwards. So endocarditis has long lasting effects. So once these organisms get inside your body and get inside your hematogenous spread, it can cause endocarditis. Endocarditis is an infection. It causes inflammation of those valves, and this causes the pathologies and the consequences which are way beyond our scope to manage afterwards. Next one, it can cause pericarditis. It can get inside of your heart. It can affect the layers of the heart. It can cause pericarditis, which is inflammation of the pericardium, which is the outer layer of what? Of your heart, which encloses your heart. If there's any pathology inside of your pericardium, it's going to affect the heart in many ways. The heart cannot relax. The heart cannot compress the way it used to. So once the patient is subjected to this kind of pathology, there are going to be multiple consequences. The body won't be getting enough blood, which it was used to get. So due to both of these pathologies, the heart is going to get affected in a major way, and maybe it cannot get back from that, because a patient which is suffering from endocarditis. So one major problem that we will deal with getting the endocarditis, you will go for the bacterial endocarditis. You won't even think of fungal endocarditis because it's not very common. It's not very common. Only those patients which are suffering from immunocompromised status or which are taking immunosuppressive drugs, only those patients you will suspect this pathology. Otherwise, maybe a person is normal and is immunosuppressed and you don't know about it. You'll go for bacterial cultures and stuff. You won't go for fungal. That's why this pathology is very aggressive, because you take on it in a very late stage of the disease. You won't go for this testing, these diagnostic modalities which confirm that a fungi is there. You won't go for them in the start because you would expect them the least. That's why the management of fungal infection starts very late, and up till that point it has caused much damage. Next on, we're going to talk about the clinical features or what it manifests with in the eye. In the eye, you will go for keratitis. It can cause keratitis, and it can cause endophthalmitis. Right? In keratitis, you look for this pathology. This is what it looks like, the keratitis. And in endophthalmitis, this is the pathology that you will look for. This is how the gross structure of the eye will be seen when you see it under the ophthalmoscope. Next on, we have diagnosis based on the culture and histology. Now that we have developed our thinking, our mind, that what clinical manifestation does it present with inside of your lungs, inside of your heart, inside of your brain, inside of your skin, inside of your eye. These five are the basic organs which get affected because of this group of diseases. This group of diseases of fungal origin. So, for example, that you have an immunocompromised patient and presents you with any kind of symptoms that we talked about in detail. In any kind of symptoms he presents to you with, you suspect that it's going to get a fungal infection. This patient is going to get a fungal infection because it's on what? It's on immunosuppressive drugs, or his immune system is down and immunomodulators are being given, or the patient is asthmatic. So in these three basic patients, you will check for what? Fungal infections before you go for bacterial and viral infections. So how do we diagnose a patient? First of all, we'll start with a brief history. That what's your name and where do you come from? What's your history of presenting complaint? You will go deep into the history of the presenting complaint of that patient. Once you've known, then you'll go for past medical history. Have you ever had this kind of experience before? Then you'll go for past surgical experience. And afterwards, you will ask these questions. Where have you been? Were you in contact with any kind of, mold or any kind of decomposed plants or animals or food? Because they're the basic source of getting this pathogen from. So you will ask about all of these things. And once you're done with your history, then you will go for your clinical examination. In your clinical examination, you will look for the skin. You will look for the skin manifestations we talked about. Once you've done that, you'll go for the eye examination. Once you're even done with that, what do? You go for the blood testing. You go for the blood cultures. And in the cultures and histology, what will you look for? In the culture and histology, this is what it looks like. When you do the culture of this pathogen, whole colony will be seen. You can see a whole colony is seen on the tray. This is what it looks like. This is actually filamentous fungi. So this is what they look like. These filamentous fungi. This is what they look like. So this is the culture and histology you will be looking for a fungal infection of this origin. And among these fungal infections, among these Aspergillosis, and the group of diseases it contains, 80% of the diseases of Aspergillosis or this origin are caused by only one organism, right? So it's very easy to identify these pathogens on the basis of culture and histology. On the culture, they will just fill the dish with this kind of structures and this kind of pathology in this kind of form. And this is what it looks like on the histology, because these are filamentous fungi and they come under the heading of astromyocytes. And this is what it looks like on histological slide. Next on, you'll go for serology. You'll go for Aspergillus antibody testing. What's Aspergillus antibody testing? You get that antigen and you provide them with Aspergillus antibody. If that antigen dies, if there's a reaction between them, it means it was Aspergillus. It's just like if there's a negative and there's a positive, you provide them with a positive and goes zero, it means there was a reaction between them. Just like that, you provide them with Aspergillus antibody testing. When that antibody is provided, that Aspergillus, that part or that this antibody is being subjected to dies off, and you know that, okay, this is Aspergillus. Next on, we have Aspergillus antigen testing, in which sample is taken and it's taken into these dishes and performed many things, which can include even their coating testing. It can include their presence testing. This is called Aspergillus antigen testing, and in this even antibodies can be used. Next on, we have real-time PCR. PCR is by far the most beneficial diagnostic modality we have. In PCR, we take that sample, we put it in the PCR, and we produce multiple copies of this DNA, RNA, and we get to know that what kind of pathogen it was suffering from, and we get to know what treatment modalities should we go for. Next on, we can also go for CT scan. Now this CT scan can be of brain. It can involve that brain abscess we talked about. It can involve that hemorrhagic manifestation in the brain we talked about. And it can involve meningitis. So CT scan can be of any region it's affecting. So in the CT scan, this is what it will look like. In the CT scan, this is what the pathology will look like. You can see this arrow. This arrow actually denotes, in this arrow, these denotes this fungal infection. And you look for these fungal infection, you look for their presence, and you will know that, okay, Aspergillus function is still inside of your body. Now, how do we confirm our diagnosis? How do we go for definitive confirmation? First of all, there's going to be positive result of both of histological testing and culture of a sample. You went for the history, right? You went for the examination, right? Then you went for what? You went for cultures, right? Then you went for histological testing, right? And next on you went for radiological manifestations like CT scan. Now that you see that you have positive culture, you have positive histological testing, you have positive CT scan showing that it's present right there, and you have a positive history, positive examination. Now you know for sure that this patient is suffering from what? This patient is suffering from fungal infection. So what's the treatment is going to be? What's the treatment is going to be like in a fungal infection? Now the fungal infections are very moderate, mild to moderate in some cases, and moderate to severe in many cases, but they have a very general treatment. So in the treatment of fungal infections, it's going to depend what kind of fungal infection or what kind of aspergillosis or what kind of aspergillosis infection is going on inside of your body. Once you know that, then you go on for the treatment. For example, it's going to be invasive. You know that it's an invasive type of aspergillosis. What do you go for? If it's primary, if it's affecting only that organ, it's going to go with voriconazole. Next one, if it's secondary, maybe it's departed from that side and affected the other side. What's going to be the treatment like? It's going to be AMB. AMB is another antifungal. Next on, we can also give caspofungin. Caspofungin is another antifungal. Now, next on, we go for pesconazole. Pesconazole is another antifungal drug. Next on, we have micafungin. So these are invasive type of aspergillosis treatment. If it's primary, you just go for voriconazole. If it's secondary, you go for all of these. And AMB stands for amphotericin B, right? Next on, we have single aspergilloma. You see a ball of fungi, a mass of fungi. What do you go for? If it's single, it's not multiple. If it's just one small ball of fungal mass, what do? You go for, if it's primary, if it's present inside of your lungs, it's going to be surgery. It's going to be surgically removed. It's not going to be there for the rest of the life. So if it's secondary, if it's gone to another level, if it's not primary in nature, if it's not still there where it started, it's going to be itraconazole, voriconazole, intracavity amphotericin B, and next on we're going to go for chronic pulmonary type of aspergillosis. Now, once you're done with invasive, now you're done with single aspergilloma, and you know if it's primary, it's just going to be surgery. It's not going to be any of these treatments because it has not yet spread. It has not yet gone secondary. It can go secondary anytime. So you stop it right here and you take it out. But if it has gone secondary, you have to go for these treatments. Next on, we have chronic pulmonary aspergillosis. In chronic pulmonary aspergillosis, you go for either primary or secondary. And if it's primary, you go for itraconazole, voriconazole. And if it's secondary, you go for postconazole and IV amphotericin B. It can also be given IV micafungin, but mostly IV amphotericin B is preferred in secondary chronic pulmonary diseases. Now, this stands for allergic bronchopulmonary aspergillosis, ABPA, allergic bronchopulmonary aspergillosis. And SAFS stands for severe asthmatic fungal sensitivity. Right? Now, this is a group of patients we talked about in very earliest stages of the lecture. That some patients who are very sensitive towards bronchopulmonary kind of sensitivity, and we talked about some asthmatic patients are severely sensitized towards these fungal infections. Now, this is that group of patients. So how do we treat them? If it's primary, we treat them with itraconazole, and if it's secondary, we treat them with voriconazole and posaconazole. So that's how you treat all groups of patients. If it's invasive, you treat with only voriconazole. If it's secondary, you give all of these drugs. If it's just single aspergilloma, you take it out through surgery. Or if it's secondary, you go for all of these drugs. Next one, if it's chronic pulmonary and it's not being treated and it's causing more and more opportunistic infections to happen, you go for itraconazole or voriconazole if it's still primary in nature. If it's secondary, you go for IVM for amphotericin B. And if it's those patients who are just sensitized towards fungi or having these reactions towards them, you go with itraconazole, voriconazole, and posaconazole. Next on, prophylaxis. Now, prophylaxis, what is prophylaxis? Prophylaxis is actually giving a specific amount, a specific dose of a drug to a patient before getting that disease. For example, there's an immunocompromised patient and you are putting that patient on corticosteroids, glucocorticoids. So what happens? It's going to cause its immunity to further lower down. And when it will further lower down, it will lead to fungal infections one way or another. So you suspect that this patient is going to get fungal infection and you provide them with prophylactical drugs. You provide them with prophylaxis. So in that prophylaxis, what happens is that you give them a specific regime of antifungals so that if by any chance these spores make their way into the body, there's a certain amount of body defense already prepared to counter them and not let this infection happen. For the prophylaxis, you go for the itraconazole solution, you go for the posaconazole solution, or you go for IV micafungin. Now, these are the prophylactical treatments for a patient who's going under chemotherapy, number one, who's going through corticosteroid use, number two, who's going through any kind of disease, systemic disease, which is lowering its immune system somehow. Now, this kind of prophylaxis is given in these patients. So what's going to be the outcome like? I mean, what's itraconazole versus standard care will look like? If it's standard care and we're not giving any treatment, what will be the outcome will be like? And what if we give itraconazole and what will be the outcome like? So let's see. In chronic cavitary pulmonary aspergillosis, we talked about it. What happens is that in standard care, this is what the stats look like. And in itraconazole, oral itraconazole, this is what the stats look like. 7% and 29% are above, and 7% and 21% are above. On the other side, we have 35 and 41 percentages and 24 percentages present right here. Now, in this standard care, for 6 months, you treated the patient and you got only what, 36% out, and you got what, 28. On the same level, you have seen the increased amount of percentages looking on the oral itraconazole levels. So that's why itraconazole is preferred regarding in response to or in comparison to the standard care. Now, this is natural history with no therapy over 12 months, right? Next on, what happened? This is 30% relapse of therapy in 6 months. We took off the therapy. We thought that patient is treated, but 30% of them relapsed and led to this 53%. This is what improved status is. You can see 7%, but 35% and 24% improved status in oral itraconazole treatments. And these patients get stable. You still see the stats. There's 29%, 21% patients stable. And we have 41% and 24% stable patient with oral itraconazole. So with every aspect, you can see that improved in the aspect of improved patients and the aspect of stable patients, oral itraconazole is far much better than standard care right here. Now, this is deterioration. You can see 64%, 71% deterioration is happening here. On the other side, 23 and 53% are present in oral itraconazole levels. So that's all about aspergillosis, a group of diseases which are caused by Aspergillus and has multiple clinical manifestations starting with your lungs. And if it goes into hematogenous spread, it can lead to your eyes, it can lead to your skin, it can lead to your heart, it can lead to your brain. Then we talked about how do we manage them, we manage them on the basis of our culture. We go for the culture, we go for the histological outcomes, then we go for history examinations, and then diagnostic modalities, which can also include CT scan. And once we know what type of pathology is present, we go for the treatment of it. We talked about the whole chart, that what treatment you will go for. In every case, if it's primary or secondary, you will go for the treatment options. And once they have been treated, we talked about how oral itraconazole is far much better than a standard therapy, because in oral itraconazole we have seen improved patients, we have seen stable patients in higher amount than standard therapy. So that's all for aspergillosis. And the least you can do is keep yourself in check, so that you don't get neutropenia or you don't get any kind of immunosuppressive state, so that you don't even get in contact with this kind of disease. But in some cases, you have to take some drugs. You have some kind of pathology going on inside of your body, due to which you're taking chemotherapy, due to which you're taking any kind of corticosteroids. You have to take the prophylaxis. We talked about the prophylactic treatment, and where different solutions are given. You have to take that in order to avoid such kind of pathology. So that's all for today. Thank you for watching sqadia.com.